Hi, my name is Holly Kinsicki. Thank you for having me today to talk about decision-making in elderly patients with advanced kidney disease and the role for palliative care. I have no relevant disclosures, and I hope that by the end of today's session, you will be able to meet the following objectives: to be able to explain the complexities around the chronic dialysis of the elderly patients, to identify patients who are at high risk of poor outcomes with dialysis, and to utilize a decision-making framework in discussions about the treatment of advanced kidney disease in elderly patients. A perhaps underappreciated fact is that chronic kidney disease in itself is a life-limiting condition. So when you look at the average 50-year-old, their life expectancy is another 35 years or so. When that 50-year-old has a GFR less than 60, life expectancy is shortened by about 5 years and shortened by about 11 years if they also have albuminuria. Now, dialysis is an amazing modality and treatment, but it will not restore normal life expectancy. In fact, we see that the highest mortality in our patients who start dialysis is in the first 2 months after initiation. So the decision about who to dialyze and when to start is a very important one. And though there used to be a previous dichotomy of thought about palliative care and disease-specific care, there is now this new framework in which palliative care can be provided at any age and at any stage of illness, including alongside curative or disease-specific care. And our patients with chronic kidney disease have a very high palliative care need. So I'm going to briefly discuss their high symptom burden. So chronic pain is a big issue for many of our patients. In the general population, it's estimated that about 45% suffer from chronic pain. And our dialysis patients is estimated to be higher at 50%. There is correlation of the presence of chronic pain with dialysis vintage, but the prevalence seems to be similar across modalities, whether it be hemodialysis, peritoneal dialysis, or conservative management. Those dialysis patients or patients with end-stage kidney disease that have chronic pain describe it as moderate to severe in intensity in upwards of 80% of the patients. Other chronic symptoms that they experience include restless leg syndrome, poor sleep and fatigue, pruritus, and mood disorders. Now, aside from us caring about our overall well-being of our patients, why else are we concerned about treating chronic pain? So we know that untreated pain will negatively impact quality of life for our patients. Patients with untreated pain will have higher rates of other symptoms like depression, insomnia, worse ability to cope with stress, an increased perception of burden of disease, a decreased perception of social support, and decreased overall life satisfaction. On a larger dialysis spectrum, those patients with untreated pain have an increased number of shortened or missed treatments. They have a higher rate of hospitalizations or emergency room visits, and are more likely to withdraw from dialysis. Now, unfortunately, the scope of this talk is not broad enough to talk about the management of these symptoms. That would be for another day. But I want to have you appreciate really the high symptom burden that our patients have. And I want to introduce you to a couple patients during this session. The first is an 89-year-old female with a history of a large hepatic cyst, hypothyroidism, pernicious anemia, hypertension, who was referred for evaluation of elevated creatinine noticed on labs at another provider's office. Her son is with her and is very, very concerned because the primary care doctor said that mom has stage 3 chronic kidney disease. And he's been on Google and he's read all about it, and he knows that this means that mom is going to end up on dialysis. So he wants to know what lifestyle modifications she should make. What should she be restricting in her diet? When you look at her labs, you note that the creatinine is 1.1, the GFR is about 42. Her other electrolytes are within normal and acceptable limits. She is not anemic, and her urine is without blood or protein. And when you go back to her labs in 2019, so 5 years ago, the creatinine was about the same. So the big question is, are we overdiagnosing chronic kidney disease in our elderly patients? We know that a decline in kidney function is a normal part of healthy aging. So starting at 40 years old, we expect our GFR to decline by about 6 to 7 milliliters per minute every 10 years or so. And we also know that an age-related decline in GFR or kidney function has a little effect on life expectancy or the risk of dialysis. Now, that being said, when we look at our patients over the age of 70, about 50% of them are labeled as having some type of chronic kidney disease. So the really big question is this impaired kidney function based upon labs from other clinical states, right? Our older patients are at increased risk of more advanced diseases for longer times, like diabetes or vasculitis. They're at a higher risk of acute kidney injury or medication side effects that can lead to kidney damage. Or is this more associated with the structural expected changes with aging? And really looking at the trend of the creatinine and the presence of protein or blood can give a lot of insight as to which of those two causes of the labs is really at play. And there's been studies looking at perhaps redefining what normal kidney function is. So when we look at healthy people between 65 and 75 years old, we see that the average GFR is about 76 to 83, whereas in younger patients, that's well above 100. And that the lower limit is actually between 49 and 55, which would technically classify somebody as having chronic kidney disease. So my question for you is, who do you think is least likely to need dialysis in their lifetime? Is it the 40-year-old male with a GFR of 40, a 55-year-old male with a GFR of 30, a 65-year-old male with a GFR of 15, or a 75-year-old male with a GFR of 20? And I'll tell you that the answer is D. As we discussed earlier, different GFR levels at different ages will have different implications. And this was a study of over 200,000 veterans with stage 3 to 5 chronic kidney disease that were followed over a 3-year period. And about half the patients were over the age of 75. So what this study sought to determine was the level of GFR below which the risk of progressing to end-stage kidney disease exceeded the risk of death. Meaning, at what level of GFR, based upon different ages, should we start counseling, perhaps, about dialysis decision-making or preparation? And what they found was that in different age categories, that GFR cutoff was different. So this gray box here is the patients who were likely to progress to end-stage kidney disease in their lifetime. And the black bar up here are those patients that were likely to live the rest of their life and die before ever needing dialysis or progressing. And what they found was that in the younger patients less than 45 years old, that GFR level was about 45. So a 45-year-old with a GFR of 40 was very likely to need dialysis in their lifetime. So discussions were appropriate. In those older patients between 65 and 74, that was more between 15 and 20. And in those patients over the age of 85, they were very unlikely to need dialysis in their lifetime. So just giving a framework of thought. And suggesting that we should be shifting our conversation. So instead of treating every patient with a certain GFR number the same and going through our check marks and the conversations that we are having, really looking and seeing, is this true chronic kidney disease? Is this an age-related decline? And is this patient likely to progress to needing dialysis? About 30% of octogenarians with labeled chronic kidney disease will die with an unused fistula in their arm. So that's a lot of stress with an associated diagnosis. It's medical procedures that they're going through that are perhaps unnecessary. Now, that being said, there is somewhat of an unpredictable trajectory. Acute kidney injury actually occurs in about 50% of patients over the age of 77 in the 6 months prior to them starting dialysis. So that is something that might be a little bit out of our control. But we can tailor our conversations. So asking more, what if you outlived the function of your kidneys? What kind of treatment would you want? Rather than framing it as, preparing for needing dialysis as an absolute. Our dialysis patients are aging. So those patients over the age of 75 is actually the fastest growing dialysis population. And over the 30-year period from 1980 to 2012, this group increased by 300%. Now, you may say, I just spent all this time talking about age-related decline in GFR and how older patients, may not progress to needing dialysis the same way at the same GFR levels. So why is this the case? And part of that is because we see that there's an increasing number of early starts for our older patients. And what an early start means is that they're starting on dialysis at higher levels of kidney functions, so at GFR is greater than 10 compared to our younger patients. So why is this the case? Is it that the accuracy of creatinine and GFRs are not really accurate in the older patients and is overestimating their kidney function? And that might be part of the reason we are starting to use a secondary marker more now called cystatin C. Is it that being older with comorbid conditions precipitate symptoms earlier? Again, it's possible, but what I really think is happening is I think we're confusing uremia and the symptoms of uremia with underlying geriatric syndromes. So frailty is perhaps the most common geriatric syndrome, or the most well-known, and it's defined as having at least 3 or more of the following criteria: unintentional weight loss, weakness, slowness, sarcopenia, poor endurance or exhaustion, and low activity. And if you think about your symptoms of uremia, there's a lot of similarities between uremia and frailty. We do find that our patients with chronic kidney disease over the age of 65 meet criteria for frailty twice as much as age-matched controls without chronic kidney disease. And it's not only limited to elderly patients. We actually see frailty in our younger chronic kidney disease patients as well. Those patients who meet criteria for frailty are actually started on dialysis earlier, and as we'll see in the next couple slides, have worse outcomes. So I really encourage all providers that are meeting with older patients with impaired kidney function to do a full geriatric assessment at the start, at the initial meeting, so get a sense of their dependence in ADLs or IADLs, their mobility, their depressive symptoms, or any other mood issues that they may have, their nutrition, their comorbidity burden, and their cognition, so that we can follow that and see what is related to underlying geriatric impairments and what might be contributed by chronic kidney disease or impaired kidney function. So most of our older dialysis patients have at least 2 geriatric impairments. Over 50% are frail, 80% require help with at least 1 IADL, 67% have cognitive impairment, and 33% have had falls in the last 6 months. We find that there is an association of geriatric impairments and hospitalizations. So patients who have dependence in their ADLs, their IADLs, they have depressive symptoms, or they meet criteria for frailty, are 2 to almost 3 times more likely to be hospitalized in a 1-year period. In terms of home therapies, such as peritoneal dialysis, we see that in the general population, about 30% of patients who start a home therapy will have a technique failure in 2 years that require them to transition to an in-center hemodialysis or an in-center modality. And usually that's related to a functional decline rather than a physiologic event. We find that those patients who meet criteria for frailty are at twice the risk of a technique failure, in that 2-year period as compared to others. In terms of transplant, frail patients are 38% less likely to be listed. If they are listed, they're 35% less likely to be transplanted and have an increased risk of waitlist mortality. If they are fortunate enough to be transplanted, there is an increased risk of post-transplant complications, including delirium, longer lengths of stay, earlier hospital readmissions, immunosuppression intolerance, and increased mortality. And mortality is also associated with geriatric impairments. So for our patients, our dialysis patients, The risk of 12-month mortality correlated with the number of geriatric impairments. So those patients with 3 or more impairments had 3 times an increased risk of 1-year mortality. And specific impairments were even more predictive. So having a presence of frailty, patients were at 7 times the risk, malnutrition, ADLs dependent, and also the presence of depressive symptoms put them at an increased risk of 1-year mortality. Now, I want to introduce you to Frank, who is our second patient of the day. He is an 81-year-old male with a history of high blood pressure, 2 strokes over the last year, a carotid endarterectomy complicated by severe anemia in the setting of a GI bleed, lung cancer with resection, COPD, GERD, and melanoma, who comes in with his wife for evaluation of chronic kidney disease stage 5. You learn that since his stroke, he's had slow ambulation, unsteady gait, and short-term memory impairments. His wife assists him with a lot of his activities of daily living, including cooking and finances. And when you review his labs, you find that his creatinine is 5, his GFR is 10, he has hyperkalemia, a mild acidosis, and his urine has both protein and blood with a protein to creatinine ratio of 1,000. And when you review his past labs, he's had long-standing chronic kidney disease stage 4 for at least the 3 years prior. So the presence of the protein in the urine and the long-standing nature of this advanced kidney disease suggests that he does have true underlying chronic kidney disease. He works as an author and feels frustrated by his recent medical setbacks, as he's always been very independent. He doesn't know if dialysis is for him, but his wife thinks that he should get dialysis. So when we're presented with a discrepancy between parties in a decision, whether it be family members or even different medical providers, this 4-box framework I find very helpful. And it's where we review the medical indications, we review patient preferences and quality of life, and any other contextual features that might be influencing a decision. Let's start with medical indications. We want to identify the available treatment options. So for Frank, we're going to be discussing dialysis or conservative management. We want to estimate prognosis with both of these modalities, and we always want to ask permission to discuss prognosis with the patient or family member. We want to evaluate risks and benefits and review any practice guidelines that may be available to help guide our medical recommendation. So will sharing prognosis influence treatment choices? So this was a study where hemodialysis patients were interviewed and were asked if they thought they had at least a 90% chance of being alive at 1 year. And after the patients were surveyed, the nephrologists were asked if they thought the patients that had at least a 90% chance of being alive at 1 year. And what they found was that there was a big discrepancy in what the patients thought and what the providers thought. So 81% of the patients said, of course, I think I'm going to be alive in a year, but the nephrologists thought that was true in only 25% of the patients. Those patients with optimistic views on prognosis preferred life-extending care. But when they were asked, if you were seriously ill, what kind of care would you want? 54% reported that they would want care focused on relieving pain and discomfort rather than extending life. But unless the prognosis is shared with patients, they're not going to be able to make these decisions. This was a similar study looking at approximately 1,000 dialysis patients who were asked, how long would you guess people your age with similar health conditions usually live? Now, 40% of the patients said that they were uncertain, but of those patients who responded, 33% said that they had at least 10 years or more, 15% said 5 to 10 years, and 11% expected less than 5 years. Now, when we look at the average survival of patients on hemodialysis in the United States, the average life expectancy is less than 5 years. So again, there's a big discrepancy in what patients expect, and what may be realistic for them. For those patients that had prognostic expectations more than 10 years, They were less likely to have documentation of a surrogate decision maker or treatment preferences, and they were less likely to value comfort over life extension. They were more likely to want CPR and mechanical ventilation. So again, if we're not fully informing patients about their expected prognosis, they might not be able to make appropriate decisions that correlate with their values. Now, we don't have a crystal ball. We cannot predict the future. But what we can do is say, is this patient at a high risk of a poor outcome with dialysis? And we have a couple tools to use to help guide that. So the first and probably easiest tool we have is the surprise question. The surprise question has been validated in different clinical scenarios, but in our case has been validated in chronic kidney disease stage 4 and 5, the hemodialysis population, and the peritoneal dialysis population. So it's asking, would I be surprised if this patient died in the next year? And what they found was that in those patients in which the provider said, no, I would not be surprised if this patient died, they had a higher one-year mortality. Now, who were those patients? Those patients were older, they had more comorbidities, they had worse functional status. So this shows that our, underlying kind of gestalt and how we think about prognosis when we see and evaluate a patient, is somewhat predictive of those patients that might be at high risk of poor outcomes. This was a study that came out a couple years ago now from JAMA that looked at the one-year mortality after dialysis initiation among older adults defined as those over the age of 65. And I like this study because this is pretty easy to pull information from a chart, So they found that the older the patient is, the higher the risk of mortality. So those patients over the age of 85 had a 70% one-year mortality. The number of comorbid conditions also correlated. So those patients that had more than 4 comorbid conditions had a 60% mortality. Patients with ADL dependence had a 73% mortality, and those patients that started in the hospital, their dialysis, had a 62% mortality at 1 year. The Charlson Comorbidity Index is more involved than the prior two tools. This has also been used in various clinical scenarios, but also in our dialysis population. So this was from the University of Pittsburgh, looked at close to 300 dialysis patients over a 2-year period, and we used this comorbidity index. So different comorbid conditions are given different weights, as you can see here, and patients are given 1 point for every 10 years over the age of 40. And you add up their score, and then you can stratify them into low, moderate, high, or very high comorbidity groups. And what this study found was that for every unit increase in the comorbidity score, there was an increased risk of hospital admissions and mortality. So if you look at this chart here, the top solid line is the low comorbidity risk group. And they had a 97% one-year survival, so did pretty well on dialysis. When you look at the bottom dotted line, this is the very high risk, or the very high comorbidity group, and they had about a 50% one-year mortality. So if dialysis is not the option, then what is the other option? The other option would be conservative management. And in 2010, the Renal Physicians Association described conservative management as an acceptable and active treatment in which patients have the right to forego dialysis. And they were very intentional with the language they used, I think, because it really portrays it as an active and thoughtful treatment. It's not just what happens when somebody doesn't want dialysis. So what would conservative care look like? So the model will vary based upon where it's being delivered, but really it's a combination of palliative care and continued care of advanced kidney disease. So we are identifying and treating pain and symptoms. We're providing physical, psychosocial, spiritual care, engaging in advanced care planning, and identifying increasing care needs and hospice eligibility. All at the same time, we're still targeting treatments of chronic kidney disease, anemia, fluid management, electrolytes, and nutrition. Now, for most patients, dialysis will offer a survival advantage. It's estimated through various studies that conservative management, the median survival can range from 6 to 13 months. So there is some lead time bias in this depending upon when the decision about conservative management was made, if it was made early in a chronic kidney disease stage 5 or very late in the course. So there's two main studies, neither of which are from the United States, that compared really mortality and survival with dialysis versus conservative management. So this was a retrospective study from the UK of patients in 4 nephrology clinics who were over the age of 75 and were estimated to need dialysis in the next 18 months. And they were enrolled in a clinic that was multidisciplinary, had physicians, nurses, counselors, psychological support, and could either choose dialysis or conservative non-dialysis therapy. And they were allowed to, change their mind at any point, and the end point that they looked at was mortality. Now, perhaps, not surprisingly, the dialysis group had a better survival. So this top solid line is the dialysis group. Bottom gray line is the conservative care group. At 1 year, survival in the dialysis group was 84% compared to 68%. At 2 years, it was 76 versus 47%. But then what the researchers did was that they looked at certain subpopulations. So they looked at patients with high comorbidity scores, defined as having 3 or more comorbid conditions. And as you can see here on the chart on the right, in those patients with high comorbidity scores, the survival curves overlapped. And a survival benefit that was statistically significant was not present when you controlled for patients with high comorbidity scores. Similarly, they looked at patients with ischemic heart disease, defined as a history of a heart attack, anginal symptoms, a stress or cath in the past, or ischemic changes on an EKG, and again found that in patients with ischemic heart disease, there was no significantly increased survival benefit with dialysis. This next study was from the Netherlands, and it looked at 311 patients over the age of 70 with a GFR less than 20, and they had similar comorbidity scores. So they controlled for that already. And what they found was that about 2/3 chose dialysis, 1/3 chose conservative management. The conservative management group was older. And what was interesting is that of the 200 in the dialysis group, 40% either died before needing dialysis or did not progress before the end of the study, and 12 had changed their mind from dialysis to conservative management. Now, what this study did, which was a little bit different, was they looked at different time points to see if that lead time bias played any role in differences in survival. And they stratified based upon age. So in those patients that were between 70 and 79 years old, which is this column on the left, regardless of the time point that they looked at, whether it was the time from decision, the time the GFR was 20, less than 15, or less than 10, dialysis had a survival advantage. But when they looked at the patients who were over the age of 80, regardless of the time point that was looked at, the survival curves overlapped, and there was no significant survival benefit with dialysis as compared to conservative management. So the big take-home is that in certain individuals, dialysis may not offer a survival advantage, specifically in older patients, greater than 75 years old with high comorbidities or ischemic heart disease, or in our older patients over the age of 80. Now, evidence is limited, right? These studies are inherently flawed. We can never control for why patients may choose one modality over another. We will never be able to have a randomized controlled trial looking at this. The outcomes that they look at in these studies are mortality, but what other important outcomes to the patients are there, and how is that influenced based upon the modality? But again, the take-home is that dialysis will offer a survival advantage to most, but it is reduced or perhaps not apparent in certain populations. So we want to, really share and explore with Frank. We want to share that uncertainty exists. So saying something like, given your age and your other medical problems like your history of strokes, I worry that you are at high risk of setbacks and poor outcomes with dialysis, including limited survival. Life may be longer with dialysis, but it's not clear. And knowing that, what is most important to you in whatever time it is that you do have? So he notes that the most important thing for him is to not be in pain. He hopes to regain some strength and energy. He also wants to be upright. It's important that he can walk. He does not want to be bedridden. And he wants to be able to think and enjoy time with his family. He continues to work, and he recently was offered this achievement award and invited to travel for public speaking engagements, which he would like to do. And he wants to travel for pleasure. And he worries that dialysis would change what his life would look like day to day and his ability to do these things. So this really focuses on the quality of life, which is going to be very, individualized based upon all the patients that we see. And what we find is that, you really don't know what someone values until you ask. So this was a study evaluating health outcome priorities of patients 60 years and older with advanced chronic kidney disease, so stage 4 or 5, not yet on dialysis. And what they found was that the top health priority was actually maintaining independence, with 49% ranking that as number 1, followed by survival or staying alive, ranked by 35% of the patients. And then third was reducing pain. And what was surprising was that nearly half of the patients ranked survival or staying alive as their third or fourth priority. And this is important because that might be surprising to some providers about what matters most, and again, really highlights that we have to ask to really find out. So what does life on dialysis look like? And it's important to explain this to patients, right? Dialysis in centers 3 times a week for 3 to 3.5 hours a time, and then you also have travel back and forth to the center. Some symptoms of chronic kidney disease or uremia may get better, like nausea, but dialysis itself does come with symptoms such as cramping, and often post-dialysis fatigue is one of the most troublesome symptoms for our patients. Patients will require a surgery for access placement and may require future interventions to keep that access working well. And most patients will start dialysis in the hospital. So looking at over 400,000 Medicare beneficiaries over the age of 67, almost 65% started dialysis in the hospital, with about a third or 36% being hospitalized for greater than 2 weeks. And you can imagine that a 2-week hospitalization in an older patient can lead to some functional setbacks. And with that, studies have looked at how long do patients spend in a facility, so a hospital, a rehab, or a nursing home, in that 1-year period following dialysis initiation. And this was looking at 28,000 patients over the age of 67, and found that on average, patients spent about 2 months, or about 59 to 67 days in some type of facility. There was an increasing time spent with increasing age and the presence of dementia, and the longer somebody spent in a facility, it was correlated with 1-year mortality. So this is a really interesting study that looked at, again, the differences in outcomes with dialysis and conservative management. So it was an observational single-center study of about 200 patients over the age of 70 with end-stage kidney disease. And it compared those patients who opted for dialysis, which is this bottom bar here, to those who opted for conservative management, which was the top. And they found that there was a survival benefit. So the dialysis group lived about 37.8 months, 38 months, compared to about 14 months in the conservative therapy group. So patients lived longer with dialysis. But then the researchers looked at what they defined as time lost. So it was time spent admitted to the hospital, time spent traveling back and forth to dialysis, time spent at dialysis, and reported recovery from the post-dialysis fatigue that I mentioned earlier. And when they looked at that, they found that though the dialysis group lived longer, 47.5% of the days survived was in this time lost category, compared to 4% of the days survived in the conservative therapy group, meaning that though time is longer on dialysis, what that time looks like is very different than what it may look like in the conservative therapy group. And again, this is just important to share because based upon different patients' values, some patients may be accepting of this and other patients may think that this is not compatible with what they value in terms of their quality of life. Will dialysis help improve functional status? So it's, unlikely. In a study looking at just under 200 patients around the age of 75 that started dialysis, they found that at the start, 79% were care dependent. At 6 months, 18%, so some patients did improve, though 34% remained stable, 40% had a decline in their functional status, and 8% had died in that 6-month period. What they also found, though, that there was an increase in caregiver burden during that time. And when patients are surveyed about what drives their health decisions, caregiver burden and stress does often play a role. Now, a much smaller study looked at the functional changes in conservatively managed patients. So this looked at 46 patients who were conservatively cared for and measured their functional status using the Karnofsky Performance Score monthly from when their GFR was less than 15 until they died. And as you can see here, that, though their functional status did not get better, it seemed to be maintained and really did not get worse until about 1 to 2 months prior to their death, suggesting that if maintaining functional status is important, perhaps conservative care, would be a better modality. Will dialysis improve cognition? So cognitive function and cognitive impairment is present in about 60% of our elderly dialysis patients. Chronic kidney disease is associated with a decline in cognitive and executive function. And we find that when patients transition to dialysis, it is associated with a significant loss of cognitive function, more so with hemodialysis than peritoneal dialysis. And we think that this is likely related to reductions in cerebral blood flow during treatment, and that there's just subclinical repetitive, declines in cerebral blood flow that might be related to, ischemia and further cognitive decline. So we lastly want to look at patient preferences and contextual features. So patient-centered care does not mean we should blindly follow wishes. We want to understand the reasons behind the request. So is there a misconception of survival benefit or quality of life or outcomes with the dialysis or with whatever treatment is being discussed? Are there family or financial reasons? So what other contextual or non-clinical factors are playing a role? We want to explore hopes and expectations, identify concerns about the future, and to determine any limitations in quality of life or health conditions in which the patient would consider foregoing a life-supporting therapy. And sometimes we have to, explicitly define the treatment options, saying something like, some people want to live as long as possible and choose dialysis, even at the risk of frequent hospitalizations and less independence. Others wish to focus on quality of life and prefer treatments focused on symptoms without dialysis, even though this may mean that life could be shorter. Do you have a sense of how you feel about this? And often, we might want to consider asking if a patient or family member would want to hear a medical recommendation based upon the values they shared of what treatment may best fit with the values. So, asking, if it would be okay to share a recommendation. And, in this case with Frank, saying something like, it seems like independence is most important to you. I worry that dialysis would increase the time you spend interacting with doctors and hospitals and may be detrimental to your quality of life without offering an extended survival. And I think that conservative management of your advanced kidney disease would best fit with your goals. Now, it was very clear in this case, Frank was very clear that he did not want dialysis, he wanted conservative management. We continued lab checks and medications for chronic kidney disease. The main symptoms he experienced was pruritus and fatigue, and he was able to travel. He went on a 3-week trip. He went to Egypt. He went to England. He went on a cruise. He was able to do these things that he really wanted to do. And we managed him for about 2 years, and then at that time, he was actually found to have metastatic cancer and was transitioned to home hospice. Now, something that I want to point out and really encourage everyone to keep an eye out for is that the end of life of our patients that are on dialysis are really heavily integrated in the medical inpatient hospital system. So 84% of patients with end-stage kidney disease are hospitalized within the 90 days prior to their death, and 28% are hospitalized 3 times. So when you think about patients that you see coming in and out and then coming in again to the hospital, right, this should raise a flag that perhaps clinically things are changing, and this should be a time to try to engage them in advanced care planning. And on average, these are not short hospital stays. Patients stay on average about 17 days during these hospital stays. So there's plenty of time to try to help engage patients and family members. So I really encourage you to try to identify these patients because they are the ones that are going to be at high risk. When we look at the intensity of care in the last 30 days of life of our patients who receive dialysis compared to patients with heart failure or patients who have cancer, we find that more patients who receive dialysis are hospitalized in the last 30 days, 76%. More of our patients die in the hospital, and less of our patients utilize hospice. So again, I think that we can really do better for our patients at the end of their life. Some patients will stop dialysis prior to death, and there's going to be a variety of reasons for doing so. And most patients, about 70%, will die within the first 2 weeks. The median time is 7 days. Now, there is longer survival associated with more residual renal function. So if somebody is new to dialysis, on dialysis for a couple of weeks or months, still makes lots of urine, and still has some residual function of their kidneys, they may live longer than this time frame. Whereas somebody who is anuric and does not make urine, their time frame may be shorter, but this is what we would expect, on average. In terms of referring to hospice, it would be if somebody is discontinuing, so stopping dialysis, or declining dialysis for wanting conservative management, that has a creatinine clearance of less than 10 or 15 for diabetics, creatinine of 8, and other supportive documentation. So they have hepatorenal syndrome, they're symptomatic of uremia, they're oliguric, not making, much urine, high potassium, fluid overload, factors like this. Technically, a dialysis patient who wishes to continue dialysis and has a non-renal terminal disease with a prognosis of 6 months should be able to enroll in hospice and continue to receive dialysis. So, for example, somebody that has biopsy-proven diabetic nephropathy who develops end-stage kidney disease, is on dialysis, and then develops a metastatic cancer and wants to enroll in hospice under the cancer diagnosis should be able to continue receiving dialysis, though I can't say that I've seen that happen often, and it is difficult, but in theory, we should be able to do that and to advocate for our patients to do that if that's what they want. So in conclusion, the elderly population has unique clinical factors to consider when discussing the treatment for advanced kidney disease. Prognostic tools that we can use include the age, comorbidity scores, and the surprise question. Shared decisions should be made in which medical indications, patient preferences, quality of life, and contextual features are reviewed. Dialysis may not offer a survival benefit in elderly patients with high comorbidity scores or ischemic heart disease, and may not improve functional or cognitive status. Conservative therapy with concurrent palliative care should be offered to these patients as an active treatment. So I want to thank you. If there's any questions or comments, please feel free to reach out to me via email or social media. Thank you.